Good morning. I wanted to thank Professor Isaac and Dr. Osada for this very kind invitation to this so exciting and well-run meeting. Hip resurfacing was developed in the early 50s by Surgeon Charlie in this country. He thought that resecting the femoral head could have been avoided. Unfortunately, his Teflon hip resurfacing prosthesis were out at very short term. In the 70s, several major hip surgeons all around the world developed metal on polyethylene hip resurfacing implants. The results were good at short term, but at the mid-term there was an unacceptable incidence of mechanical failures. Surgeons mistakenly identified a vascular necrosis of the femoral head as the major cause of these failures, and as a result, the concept of hip resurfacing was completely abandoned in the 80s. The concept of hip resurfacing has been then resurrected in the 90s by Derek McMinn and Ronald Tracy. They correctly identified polywear as the true cause of the metal on polyethylene hip resurfacing failures, and because of the availability of new high-tech metal-on-metal bearing with low wear, developed the PHR. The advantages of hip resurfacing are several. The femoral head is preserved, there is no opening of the femoral canal, femoral neck anteversion is maintained, recovery is faster, the functional outcomes are good, percussivity is maintained, there is a normal loading of the proximal femur, where is low, strenuous activities, including high impact sports, are permitted. The dislocation rate is quite low, and finally, in case of a failure, it can be easily converted to total hip arthroplasty. Several authors reported at both short and mid-term good clinical outcomes and a high rate of survival with the BHR. As a result, several implant manufacturers developed their own metal-on-metal hip resurfacing implants. They look pretty much the same, but in reality they differ. They differ a lot. They differ in terms of design, metallurgy, manufacturing, clearance, and even more importantly, they differ in clinical outcomes. Data from both the Australian Joint Registry and the England and Wales Joint Registry show that in some of these, the revision rate is statistically higher than with others. As a result, some of these implants have been recently dropped from the market. Over the last couple of years, several criticisms have been raised in the orthopedic community against the use of hip resurfacing. It has been said that the revision rate is much higher than the standard total hip arthroplasty, that is contraindicated in young female patients. Surgeons are extremely concerned about the risk of complications such as femoral fractures, increased metal ion levels, and of course pseudotumors. Although data from the Australian Joint Registry clearly show that the incidence of revision is just slightly higher with hip resurfacing than with the total hip arthroplasty, over the last 5 years there has been quite a significant decline in the use of hip resurfacing. It is interesting to note that females had a higher revision rate than males. However, after adjusting for head size, the revision rates are the same. These results are also confirmed from data from the England and Wales Joint Registry. Did this decline indeed these criticisms affect my hip resurfacing practice in any manner? The answer is not at all. Why? Because I believe that hip resurfacing accomplishes the most important requirements for optimal hip arthroplasty much better than a standard total hip arthroplasty. Number one, it replicates hip anatomy, biomechanics and function. Number two, it preserves the proximal femoral bone. In between January 2001 and the present, I've done more than 1,000 hip resurfacing operations. In 670 hips, I used the BHR, and in 346 the ADEPT. At a mean follow-up of 4 years, the clinical outcomes are quite good, and the survival rate is 98.7%. In my practice, I care a lot about good implant positioning. In my series, the mean acetabular component inclination angle is equal to the femoral neck. I do not like mini incisions. I do not like mini exposures. I use a standard posterolateral incision to the hip. The length of the incision is between 10 and 15 centimeters, depending on the patient, of course. And I like to obtain this kind of exposure of both the socket and the femoral end. And these tools are extremely important to my practice. In case they are not available, I just don't do it. I recommend the use of a standard acetabular component when a good alignment with a coverage more than 70% can be achieved. If this is not the case, the cup with the supplementary screw fixation should be utilized. In our practice, hip resurfacing is a great indication for our active osteoarthritis patients. In some of these, there are large cysts in the head, and we like to fill them up with bone chips, which are harvested while cleaning the socket. I used it successfully in AVN patients, and in our series, there are no differences in terms of survival between our AVN and our OA patients. We used it in patients with post-traumatic acetabular deficiencies. In some of these patients, the removal of the hardware is not necessary. As you can see, by using hip resurfacing, it is possible, even in severe cases, to obtain great functional results, such as in this particular patient. This video was shot 6 months after the operation. Surgeons are extremely concerned about postoperative femoral neck fractures. I used it successfully in patients who previously had a femoral neck fracture. We used it in patients who previously had a femoral neck osteotomy. Hip resurfacing can be a great indication for cases like this. Patients with previous femoral fractures with hardware implanted in their femoral canals, which resulted to be impossible to be removed at surgery. We used it in patients with severe hip deformity, such as in this slipped femoral capital deficit patient who was doing quite well 9 years after he was treated with hip resurfacing. We use it in patients with CVH when there is enough bone in the pelvis. We recommend the use of a standard acetabular component. By the way, quite a good functional outcome. This patient was able to run a marathon within 1 year after he was treated with hip resurfacing. When the femoral head is dislocated in a too far to proximal position, the cup with a supplementary screw fixation should be used in order to relocate the femoral head in the true socket restoring the correct central rotation of the joint, and of course, implanting the cup with the right inclination. However, in patients with a too short head or a too short neck, standard hip resurfacing technique cannot be used because of the risk of impingement or insufficient offset. However, as we are fan of hip resurfacing, we developed a special technique consisting of head lengthening with bone chip augmentation in order to expand the indications for hip resurfacing also to patients with severe deficiencies of the femoral head. This technique is similar in concept to any infection or grafting techniques which have been successfully used in several hip operations for both acetabular and femoral augmentation in primary and revision surgery and in association with both cemented and uncemented implants. The goals of this technique include to obtain a correct reconstruction of the femoral head, to restore the joint offset, to avoid impingements, to optimize stability, and of course to equalize leg length. At surgery, the amount of desired lengthening is accurately measured in this manner, with the containing ring in place, bone chips which are harvested while ringing the socket and while trimming the head are implanted to the top of the patient's head, obtaining a result of this kind. Then we use this cannulated impactor in order to impact the grafted area to reconstruct the head. And here you can see photos taken prior and after this particular reconstruction. In my practice, I've treated this particular technique several patients with a short head. Here you can see an augmentation of 12 millimeters, the good clinical and radiographic result 2 years after the operation. And there are also short head cases in which the deformity is so severe that it almost fits you, such as in this particular patient in which there were 2 femoral heads. Here the challenge was to identify the true head. Here you can see what I did at surgery. I resected the fake head. Of course, the true head was insufficient, was too short. Therefore, it was augmented, and there you see X-rays taken 4 years afterwards. This patient is now doing quite well and is now engaged in sport activities as well. In our practice, we have also treated several short neck patients with this particular reconstruction. Short neck is quite a frequent deformity in patients who previously had Perthes disease, and this is the first patient in which this particular technique was used, a lengthening of 14 millimeters, and there you see X-rays taken 6 years afterwards. And this is another more recent similar case and similar good result in another patient who had a Perthes disease in which the cup with supplementary screw fixation was utilized. And there are also patients with heads of a normal length but with severe bony deficiencies who may take advantage of this particular reconstruction. Here you can see the severity of the lack of bone in this post-traumatic case. There you see the use of the containing ring of our special instrumentation. This has been manufactured by Finsbury. There you see the use of the cannulated impactor. And there you see how the reconstructed femoral head looks like. And finally, the femoral component is seated according to standard cementing technique. And these are the X-rays taken prior and after this particular operation. In between January 2001 and January 208. I've done 32 lengthening cases. Median lengthening is 12 millimeters. Functional results are the same as the standard cases. To date, only one patient has been revised because of a socket mechanical loosening. In our resurfacing patients, we have done a number of studies. We have done a gait analysis study. This showed better results compared to 28 millimeter total hip replacement. We have done a DEXA study. This particular study confirmed that the resurfacing preserves the bone stock of the proximal femur, and we also found that a slight valgus positioning of the femoral component further improves the bone mineral density of the proximal femur. People are very concerned about metal ion release. We have done a metal ion release study at 2 years, and we found no differences in ion levels between patients who had metal-on-metal hip resurfacing and patients who had 28 millimeter metal-on-metal total hip replacement. And we have just completed a metal ion study at 5 years, which will shortly come out in clinical orthopedics. In that particular study, we found that the ion levels do not change in between 2 and 5 years. We still have some contraindications for resurfacing. We don't do it in patients with no femoral head. We don't do it in patients with no femoral neck. And we don't do it in patients with bones gone. Of course, we have complications. We had 8 femoral neck fractures, 2 dislocations, 2 acetabular component loosening, 1 femoral component loosening, 1 pseudotumor, 1 internal iliac vein lesion, 1 peroneal nerve palsy, 1 crural nerve palsy. To date, 10 implants have been removed and converted to standard total hip replacement. In the vast majority of our complications, we were able to identify technical errors, such as this particular patient, in which a femoral neck fracture occurred 45 days after surgery. It was poor anesthesia. The acetabular component was implanted in a stiffer position and the femoral component in varus. In this particular patient, the problem was the bone quality. She was severely osteopenic. And this is the pseudotumor we had. Again, there are technical problems. The acetabular component, as you may see, is implanted quite steep to steep. We are extremely happy about our metal-on-metal hip resurfacing results. However, we are also investigating other potential bearing technology. And this is completely new technology. This is the buffer. It is a polycarbonate urethane cup, can be coupled with a large diameter metal heads, including hip resurfacing femoral component. It is pliable, it is a stress absorber, and it biomechanically mimics human cartilage. The elasticity of this material is exactly the same as human cartilage, and it is completely different from all the other biomaterials used in implantoplasty. Just to give an example, polyethylene is 70-fold more rigid than this material. Ceramic is 20,000 times more rigid. The number of particles which are generated at this step is the lowest compared to all the other bearing technologies, including ceramic and metal-on-metal. The shock absorption capacity, this new bearing, is the same as with cartilage on cartilage, and it differs enormously from all the other bearings. The size of the particles is the largest, and this is quite an important result because there is evidence that the larger the particle size, the more benign is the negative biological wear. The lubrication is ideal, and indeed the thickness of the foot film is exactly the same as in the normal joint, and differs remarkably from all the other lubricated bearings. There are two implant options in patients with a pristine socket. We can use the buffer alone. In patients with a deformed socket, in which the surgeon needs to remove the acetabular bone in order to restore the previous socket sphericity, you can use a metal shell featuring the buffer as a liner. How is the buffer alone fixed to the bone? By using flexible mechanical fixation. With the special tool, a groove is made in the patient's socket, and then the buffer sledge is snapped into it. And by doing so, the implant is stabilized. This technology can be used for hip resurfacing operations. Here you can see an AVN patient with a pristine socket, in which we used the buffer alone, which was coupled with the VHR femoral component. And then you see X-rays taken 3 years afterwards. You can see the optimal quality of the acetabular bone surrounding the cup. This patient is now has now a quite high level of function, and she's also able to play sports, including biking and skiing. In patients with the deformed socket, we can use the specially manufactured metal shell. In this case, the acetabular rimming is as a standard. There you see the metal shell. It has a groove in its inner part. There you see the buffer. You can see how the two components are assembled at surgery. You see how the metal shell featuring the buffer as a liner is driven home. This particular implant can also be used for hip resurfacing operations in patients with the proper socket head ratio, patients with a relatively larger socket and a relatively small head. Here you can see a good radiographic result 1 year after this particular operation. In conclusion, we believe that hip resurfacing is a surgeon and implant-dependent procedure. It can be either extremely successful or extremely detrimental. Recent criticism led to a slight decline in its use. However, with the right implants, the results of the larger volume pioneer surgeons remain quite satisfactory. We believe that the vast majority of the poor results recently reported are associated with the poor surgical technique. Hip resurfacing is a challenging procedure, and to do it successfully, large volumes and routine are needed. Finally, bearings other than metal on metal should not be neglected. Thank you for your attention.